All right. So Ramadan Kareem, hope you guys are enjoying medicine environment. It's a pretty important unit, and it's not only for the rest of the semester, but honestly for the rest of your medicine career. And these are the basics that are gonna go with you until you graduate صراحة. So it's really, really important to, especially those introductory weeks. And if you guys understand these weeks and you have a really strong basis, it's gonna really help you out throughout your medicine career. As you guys know, there's a lot of content and not a lot of time to go, so we'll be as concise, and we'll try our best to make it as informative as possible. So you guys have three main subjects: pathology, pharmacology, and micro. I will be doing your pathology and pharma, and Ahmed will be doing your micro. So starting off with pathology. So this lecture I think was added new to you guys. It's talking about like tissue, how to do like tissues and the stains. And it's actually good because these stains, you're gonna see them a lot during your pathology. And like if you guys know what these stains actually stand for and what they do, what do they stain exactly, it's really gonna help you out when you're looking at that question. So the most famous stain, first of all, is the hematoxylin and eosin, or you might see it in a question written as H and E. It's the gold standard chain. It's the most important. And if you guys see the hematoxylin stains actually the nuclei. So if you see that picture at the top right, you're gonna see the nuclei written as like blue or colored blue, and the eosin does the cytoplasm and it's more red. Now the other stains is the PAS, and it does like the carbohydrates like glycogen, mucin, and hyaline. Also, another famous example is the oil red O or Sudan black. You can tell from the name, oil red O would stain the fat red, and the Sudan black would stain it black. And a common exam question, for example, you're going to see which stain of those is for would stain the fat, and you would have to choose one of them. So the other two, Mason trichome and Van Geysen, it's not really used. You're not gonna see them more often, but it's good to know, the Mason would do the collagen versus the muscle, and the Van Geysen would do the collagen fibers. Now to the more important stuff, starting with the homeostasis and adaptation. So talk about, well, you guys know from foundation what homeostasis means. It's like the body's regulation. If anything goes above or below the normal range, the body tries to make it normal. And this also goes towards cells. So when cells are exposed to stress, the cells would adapt itself to survive. It would either increase in size or increase in number, or decrease in size or decrease in number. And adaptation is this new state that we have created for the cell that would help it adapt in this new environment. Now, those main cellular adaptation, we have number one, atrophy, hypertrophy, hyperplasia, and metaplasia. Know these, and they're very, very, very important. And we're going to talk about that later more, but if we have an inability to adapt, this is what causes cell death. So starting with atrophy. So atrophy, so A, if you guys remember from ATF, EMS, A, when you put an A, it means like the opposite or against or not present. And trophy means size. So atrophy means like the shrinkage. So we have the shrinkage of cells. This is due to the loss of, so we have the cell substances inside, we have the cytoplasm. We're going to lose all of these cell substances, which makes the cell shrink. And we have how it works is that we have imbalance between the protein synthesis and the degradation. So the degradation will be more than the protein synthesis. And we have three types of atrophies. We have the physiologic, which means it happens in the normal body. It's not necessarily a disease. It happens normally as a healthy person. We have embryologic remnants, meaning during embryological or fetal maturation, sometimes some certain structures are going to might take later or might have already taken it. They might disappear or like they go away. We don't really need them anymore other than the embryo. And sometimes they are present. But in this case, they usually physiologically go, and this is called physiologic atrophy. For example, thyroglossal duct, which is like a remnant of your thyroid gland. For example, the uterus after the delivery, like as you guys know, during delivery, the uterus would get bigger, and after delivery, it would get smaller. Pathologic atrophy. This is, for example, This is pathological. We have a disease in here. For example, we have a decreased workload, or call it disuse atrophy. So as you can see here, if someone has broken his leg, we're not using it anymore. This is the muscle would actually atrophy to get smaller. Loss of innervation. We have a nerve damage. It's called an denervation atrophy. Decrease of blood supply or decreased endocrine stimulation. For example, in your adrenal gland, if you guys remember from foundation, if you have decreased ACTH, your adrenal gland or the stimulation to the adrenal gland would decrease. This would cause atrophy. And lastly, is senile atrophy. This is actually, it's very closely similar to physiologic, but we have Dr. Ibrahim have put it on his on its own. It's due to old age. So basically, the normal human being, after they grow older, the cells shrink. The most important thing here is the actual size of the cell decreases, not the number, not anything else, the actual size. And also know these examples by heart because they are asked about it. Hypertrophy, on the other hand, is increase in cell size, is the opposite of atrophy. So, for example, we have increased cellular proteins inside the cell. So what are the causes? As we mentioned before, when you have atrophy, you have decreased endocrine stimulation. Here we have increased endocrine stimulation or increased workload. And a very famous example Dr. Ibrahim likes to get is hypertension. Yani this picture on the right, until now, until CVS, Dr. Ibrahim still brings the same picture. So know this picture and know this example. So we have left ventricular hypertrophy. If someone has high blood pressure or hypertension for a really long time, your heart actually adapts, or it's due to the increased workload, it has a higher pressure to push against. This would increase the hypertrophy of the heart muscles. Important thing to note, again, there's no increase in cell number, only increase in cell size. And if it continues to progress, you have degeneration, organ failure. For example, in heart failure, if you have increase in the heart size, eventually it's going to reach to heart failure. Now, onto the hyperplasia. Hyperplasia is the increase in cell number. This is separate from the other two. Before we talk about the cell size, now here's cell number. And here we're talking about this requires cells to be capable of DNA synthesis and mitosis. What does it mean? Example for in the heart, if you guys remember, cardiac muscle does not regenerate or does not replicate itself. So that can't go under hyperplasia, only undergoes hypertrophy. But on the other hand, for example, we have the skin. The skin can regenerate and it can adapt, so it can undergo hyperplasia. Now, keep in mind this is a controlled process, so it's the body's normal physiological mechanism. And if it does become uncontrolled, it can predispose to neoplasia or cancers or tumors. So there's a difference between cancer and normal hyperplasia. If it's cancerous or neoplastic, there's uncontrolled hyperplasia. But now here it's fully controlled. Now we have types here. Again, know these examples by heart. We have physiologic, again, hormonal. So if you have increased stimulation by hormones, if there's a pregnant uterus, it can undergo hyperplasia. Or compensatory. What does this mean? For example, if one of my kidneys, I donated one of my kidneys to someone else, I only have one kidney. This kidney has to compensate for both of my kidneys. So it undergoes hyperplasia. It undergoes increased cell number. Or it can be pathologic. For any reason. For example, excess hormones, again, increased stimulation. For example, in benign prostatic hyperplasia. Just know this example. Now, metaplasia is reversible replacement of one cell type for another. So we have a normal cell type. If you guys remember from Bio 1, we know in each part of our body we have certain types of cells. If those type of cells do undergo a change or become another cell type which is unusual to this environment, this is called metaplasia, and this is due to chronic irritation or stress. Now, what's the problem is, as you got each part of each type of cell has its own function depending on the part of the body where it is. Now, if you change this cell type, then the function of the epithelium is gone. It can't protect it or can't undergo this function. So, for example, we have in smoking, as you guys know, in the lungs we have ciliated columnar epithelium. Now, if we have chronic smoking or increased irritation, it becomes squamous epithelium. It can't undergo its functions like secretions, and becomes more squamous. Again, here in the esophagus, sometimes we have like reflux of acid from your stomach, and instead of it becoming like squamous, it becomes columnar. It goes the other way around, so it loses its protective function. Now, when you talk about cell injury, sometimes it's reversible and sometimes it's irreversible. Now, if it's reversible, sometimes sometimes the question can ask you what, like, it describes some morphological changes and tells you is this reversible, it's irreversible, what's that exactly. Now, the two things you have to remember, like, overall, is cellular swelling and fatty change. So what do you have swelling, for example? So when you have swelling due to the increased damage to the cell, we have decreased ATP. When decreasing the ATP, you have decreased the activity of the sodium potassium pump, and now the sodium stays inside the cell instead of the outside. And it can't enter because the pump is dysfunctioned. And wherever sodium goes, water follows. So if the sodium stays inside the cell, the water is going to follow. It's going to go inside the cell, causing the cellular swelling. Now we have other features of reversible cell injury. For example, membrane blebbing. Blebbing means like picking up like small pieces of the cell and like losing the cell size slowly. Endoplasmic reticulum dilatation, same example. Mitochondrial swelling, chromatin clumping inside the nucleus. The DNA becomes clumped together instead of the normal clumping, and increased eosinophilia. You're going to see the cells more reddish. Now, another very high yield concept, and people like the doctors, pathology doctors, like to ask about is now cell death. This is irreversible cell injury. So we have necrosis versus apoptosis. So when we talk about necrosis, this is unprogrammed cell death. So the cell dies, and like غصب عن the body. It's always pathological. Remember this, it's always pathological. And also the cell contents are released, which causes inflammation. So whatever is inside the cell, it's gonna be released outside. And due to this, like the things that are inside the cell are not outside. This is abnormal for the body. This causes inflammation. And we have loss of membrane integrity. So the membrane actually breaks off. It doesn't remain intact. This is opposite to apoptosis. Apoptosis is programmed so that this is something that the body initiates. It can be physiologic or pathologic. And usually we have no damage to the surrounding tissue. This is opposite of necrosis because the membrane itself is intact. Like the contents of the cell do not spill over. And the way apoptosis works is the enzymes are activated and they degrade the cellular proteins and DNA, which is an active process. The cell itself, the enzymes actually break down the cellular contents. Now, morphology of the necrosis. We're going to see here increased eosinophilia. So it becomes pinker or more reddish due to the denatured proteins or loss of RNA. If you guys remember, we said the nucleus is blue. Now we're losing all of these things. So now we're becoming more reddish. We have a moth-eating appearance due to the increased enzymes digesting all of these organelles. And now this is the most important part. We have nuclear changes. So how does the nucleus of the cell change? So first of all, we have what's called pycnosis. Pycnosis, as you can see in the picture below, the nucleus itself is shrinking. It's becoming smaller. So when we have shrinking and like all of the DNA is coming to one place, we have increased basophilia also. Also karyorrhexis. Rhexis means like breaking or like hitting or like breaking, like the nucleus itself is breaking down. We have fragmentation of the pycnotic nucleus. So you can see here they're becoming smaller pieces here right now. And we have karyolysis. Karyolysis is at the very end phase of the nuclear change of necrosis. And the nucleus is basically dissolved. خلاص, it's nowhere here. We have enzymes, DNases, and they basically eat up all of the DNA, and خلاص, the DNA is gone. Now, again, a very important concept is the types of necrosis. And the first one is coagulative necrosis. Coagulative necrosis is the most common, and that's I've even being asked, and typically caused about ischemia. Now, as in like there isn't blood, even like there isn't enough blood reaching a certain area, but this is in the entire body except the brain. Remember this exactly. And again, a feature of it is it preserves this basic tissue architecture. So if you can see here on the right hand side, the cells themselves are like, you can see the outline of the cells. Like you can see, like you can point out this is a cell, this is a cell, this is a cell. But if you look inside the cell, you can't see really anything. It's empty, or like a ghost. You can see a ghost appearance of the cell. Now, liquefactive necrosis, it's like when coming to description, it's ischemia that happens in the brain. That's basically it. If you basically see any question that says there's ischemia in the brain, 90% of the time think about liquefactive necrosis. And this happens with enzymatic digestion predominates the regeneration and turning the liquid into like a liquid mass. Caseous necrosis, again, when you see tuberculosis, think about caseous necrosis. Again, these are very important keywords. And it appears as a cheesy white debris, if you can see here in the picture. And you can see a granuloma. So a granuloma is like a cluster of cells, of inflammatory cells, macrophages, lymphocytes, etc. It's very, very characteristic. The fourth type of necrosis, you have fat necrosis. So you can see the cells, the fat cells, sometimes by enzymes, they can break down, and it leads to a process called saponification. So whenever these enzymes break down the fat, it causes soap formation, and you can see like these. You can see in the picture these white chalky like deposits. And the last one is gangrenous necrosis. So gangrenous necrosis is basically a coagulative necrosis but it's for a limb due to a blood loss. So if you have like the ischemia of a limb, and you can see like this picture, see it's gangrenous necrosis. Now, if you have a digangrene, and above it, due to whatever reason, due to like, for example, like destroyed skin barrier or whatever, we have a bacterial infection above it, this would cause a liquefactive component. So it becomes more liquidish or runny, other than the opposite of the digangrene. It's very common. We see it in diabetic patients and frostbite victims, since they don't like they have loss of sensation. So again, lastly, we have a calcification. So we have, again, two types of calcification. We have dystrophic and metastatic. Again, very, very important. So dystrophic, well, like if you think about the meaning of the word dystrophic means like there's like the structure is broken down, or like it's not the usual structure. So the cause in non-viable or dying tissues. So if you have any type of cellular injury or necrosis or whatever, we can have dystrophic calcification. Very important thing to note: serum calcium levels remain normal. So for example, we have a damaged heart valve or a trauma or any necrosis, and we have a calcification with the calcium levels are normal. This is dystrophic calcification. This is opposite of metastatic. Metastatic normals occurs in perfectly normal cells, but again, it's associated with hypercalcemia or high calcium. So due to whatever the reason is, if you have high calcium in the blood, and it happens due to cells which are perfectly normal, this is called metastatic calcification. So if you have a couple of questions here, I'll give you 30 seconds to answer it. Okay, so we have here an 18-year-old prima gravida measures 18 weeks gestation or examination. Okay, so we have ultrasound shows a uniformly enlarged uterus. So if you guys remember when you said we have an enlarged uterus during pregnancy, what was the cellular change that happens which increases uterine size, it's myometrial hypertrophy. So this is how the questions usually are getting, and this is what I'm telling you guys. Remember the examples that are written in the PowerPoints. Okay, another example. So here we have a 38-year-old man with health screening examination. He has a routine chest X-ray that shows a 2 centimeter nodule in the right lower lobe. The nodule has focal calcifications. So we're thinking about, okay, we have two types of calcification now, dystrophic or metastatic. So which one would it be? So a wedge resection was taken of the lung with the nodule and performed. On microscopic examination, the nodule shows caseous necrosis and calcification. So if you guys remember, whenever we have a necrosis or cell damage, what's the type of classification we have? So we said that it's dystrophic. So we have, so very important, remember. So these are the keywords that are usually getting. So we have casus necrosis and the classification. This is how we answer the question. Okay. So onto inflammation. So inflammation is a dynamic and protective response. So whenever we have injury or whatever, this is how the body reacts to the cellular injury, by inflammation. And it tries to bring all of those protective components into one place, which is where the cell injury is. Now, those 5 R's, this is the basic of any type of inflammation. And it's gonna if you understood those 5 R's really well, you're gonna understand the lectures for the acute and chronic inflammation. So first of all, have the recognition of the injurious site. So you have to know, how does the body recognize the inflammation? How does it recruit the leukocytes to bring them into one place? How does it remove the agent after it's the damage, or like the bacteria or whatever is causing this? And how do we regulate the response? How we don't make it like too over or too little? And at the end, how do we repair? How do we resolve? So starting with acute inflammation. So acute inflammation is inflammation, I can tell from the name, it's a rapid response to the injurious agent. Delivers like host defense mediators to the site of injury. Most importantly, remember, neutrophils are very, very important, and they're very key players of acute inflammation. And if you see a question with, for example, increased neutrophils, think about what's it called, acute inflammation. So what are the cardinal signs of inflammation? So we have, you probably studied before, so rubor, calor, dolor, tumor, or loss of function, or redness, hotness, pain, swelling, loss of function. So redness, what is caused by hyperemia. So we have increased blood flow by vasodilation. Again, hotness, same thing. We have vasodilation, we have increased blood flow. This is what causes the hotness. And the pain, so we have damage to the nerve endings. And tumor, we don't mean a cancer, I mean like the swelling. So like all of these, remember, as if like you broken your elbow or whatever, like what are the things that you're gonna see in acute inflammation? And we have loss of function. So for example, if I broke my elbow, I wouldn't really be able to like swing a bat or like play tennis or whatever. I wouldn't be able to use my arm properly. And we have also systemic effects. So we have fever, malaise, loss of appetite, etc. So vascular changes really quickly. So first of all, number one, whenever we have this inflammation, what exactly happens on like a blood vessel level? So we have transient vasoconstriction at the beginning. It lasts a few seconds. First, we want like the platelets or the coagulating factors to stop the bleeding, whatever it is. And this lasts only a few seconds. After the vasoconstriction, after we've made sure there's no bleeding, you have vasodilation. Now, it's induced by histamine and nitric oxide. And this causes, we want a lot of blood cells to go to this site of injury and try to attack or repair or remove all of the debris caused by the damage. We also have increased permeability, again, for the same reason. We want proteins, we want RBCs, for example, we want fibrin and fibrinogen to go and help us to, like close up any wounds or like coagulate on any blood vessels. And stasis. At the end, we have concentrated blood cells. So we have a lot of blood going into one place, and this increases the blood viscosity or like the density due to the slowed flow of the injury. Imported again, an important comparison, we have exudate versus transudate. So exudate is due to, oh yeah, okay. So we have exudate due to increased vascular permeability, so if you can see, if exudate, if you, for example, do an analysis at the beginning, we're going to see a lot of proteins, we're going to see a lot of cells, and this is due to inflammation or cancer. So if we have any injurious stimulus, we're usually going to see exudate. But transudate, on the other hand, is due to imbalance of pressures. So if you guys remember hydrostatic and osmotic pressure, the hydrostatic pressure would push from inside the blood vessel, push it outwards, osmotic would push it inwards. And if there is any imbalance, if you have the hydrostatic less or hydrostatic more than the osmotic, that would cause the fluids to leave the blood vessel into the surrounding tissue, and this would cause the transited. So if you see the content of the transited, it's going to be low in proteins, and we're not going to see a lot of cells because we don't really have increased permeability, just the waters. We have a lot of water going out. So if we have hypoproteinemia, low osmotic pressure, heart failure, we have increased hydrostatic pressure or lymphatic congestion. Okay, here, now this is for your reference. I'm not going to read all of this, but we have types of morphological patterns of acute inflammation. Now, first of all, we have the serous. Serous, you can tell from the name, it's mostly watery. We see cell-poor fluid, and it's usually derived from plasma or mesothelial cells. So, for example, famous examples are skin blisters or effusions. So, for example, you have pericardial effusion. The pericardium of the heart is, there's a lot of fluid in it. This you would see, or usually serous. Wouldn't see a lot of proteins or much cells in there. On the other hand, we have fibrinous. Fibrinous happens with severe injury. By the way, in serous, it's still exudate, but it's not transited. It's still exudate, but it's cell poor compared to the rest of the others. In fibrinous, we have severe injury and high vascular permeability. We're going to see a lot of cells leaving the blood vessels. We're going to see a lot of fibrinogen, for example, leaving. And this and another example is fibrinous pericarditis. So we can see either serous or fibrinous, depending on the stimulus, depending on the content of the fluid itself. Now, suppurative or purulent, you're going to see a lot of pus. So we're going to see a lot of neutrophils or necrotic cells. An example is acute appendicitis or any abscesses. And ulcerative is, again, like an ulcer. So if you guys know in the stomach, al-qurha, it's basically like a defect on the surface of an organ or a tissue. An example is peptic ulcer أو هي القرحة يعني. Now, finished acute inflammation. Now we're talking about chronic inflammation. Now, major causes of chronic inflammation is persistent infection. So if I think you guys already talk about tuberculosis. So sometimes we have tuberculosis that's always there, or very hard to treat, or it's latent. We usually have chronic inflammation. We have inflammation for a long time, or prolonged exposure to toxins. So we have exogenous and endogenous toxins. The exogenous is, for example, environmental agents like silica that are outside the human body, or endogenous, like internal components of like toxic lipids and atherosclerosis. And also, by the way, remember the exogenous and endogenous toxins, because Dr. Ibrahim usually gets what are the exogenous and endogenous toxins. And if you have autoimmunity, so your immune system is constantly attacking parts of your body. So this causes, again, chronic inflammation. Okay, so now we have the role of macrophages in chronic inflammation. So inflammation, if you have two stages of macrophage activation, we have M1 and M2. So this diagram at the bottom is pretty useful. So usually M1 is activated by interferon gamma or microbial endotoxins. And if you can see, the role of it is microbicidal actions or inflammation. So think of the state of inflammation. If you're like, خلاص, and your body is fighting this microbe, what did it do? It would usually be activating M1. So to do, like, to try to kill the bacteria, or it would stimulate activation, stimulate inflammation. Now, on the other hand, we have M2, which is stimulated by interleukin 13 and interleukin 4. Think of M2 as, what happens after the storm, after the inflammation. So think about tissue repair, think about fibrosis, anti-inflammation. خلاص, your body got rid of this stimulus or like injury. It's trying to repair itself. So this is what M2 does. So again, the two important cells in chronic inflammation are macrophages and lymphocytes. Other than, if you guys remember, again, this is opposite to acute inflammation. We said neutrophils are the most important. Here it's macrophages, most importantly, and also lymphocytes. So macrophages and lymphocytes, they work together to activate this inflammation. So macrophages is an antigen presenting cell, if you guys remember. And what it do, it would present the antigen to the T lymphocytes, and it would use cytokines to look in 12 and 23. And it would activate the T lymphocytes, and the T lymphocyte would go on the other hand and like release interferon gamma. Whenever you see interferon gamma, think about macrophages. And the cycle goes on. So the idea behind this is that macrophages and lymphocytes, they go into the cycle that this activates the macrophages activate the lymphocytes, and lymphocytes activate the macrophages. It's like a positive feedback mechanism. Now, other inflammatory cells, eosinophils also, Dr. Ibrahim likes to ask about this. Whenever you see a parasitic infection or allergies, think about eosinophils. This is where you're going to see eosinophils. And two components of eosinophils that are important is the ataxin chemokine and granules containing major basic protein. Just memorize those two components. Also, mast cells, they're actually important in both chronic and acute inflammation. So in acute reactions, we have the IgE antibodies. They go and bind to the mast cells, if you can see on the diagram, and they cause mast cell degranulation, and the mast cell would release all of its things inside, so the histamine, and it would, sometimes this is the cause of like anaphylactic shock or allergies, for example. In a chronic inflammation setting, they would actually contribute to fibrosis. So remember, in chronic, so mast cells have different roles in acute and chronic inflammation. Now, in another type of inflammation is granulomatous inflammation. So it's a distinct pattern of chronic inflammation characterized by, we have a group of or activated macrophages called epithelioid cells, and we have scattered lymphocytes. So the epithelioid or giant cells, which are a group of epithelioid cells, which are activated macrophages, they develop like they go together and fuse together to form these like giant cells. So we have two types of giant cells. We have Langhans and foreign body. Very, very important. Langhans cells are, so they're usually associated with immune activations as in tuberculosis. And their nuclei are arranged like on a periphery. So if you can see the bottom picture, they're usually on the side here. They're not really in the middle. But the foreign types of, if you have like a foreign body inside of you, so sometimes, for example, if you have like a knife into your arm, whatever, and take a biopsy of this, you're gonna see nuclei like haphazardly or like randomly. You can see these epithelioid or giant cells. So this is like a comparison overall of acute versus chronic. Know these differences as well. So here another question. So a 43-year-old woman they have a chronic cough and fever and weight loss for the past month. Just a graph reveals multiple nodules. Some would demonstrate cavitation in upper lobes. A sputum sample reveals presence of acid-fast bacilli. Which of the following cells are most important in developing her lung lesions? So if you guys remember anything, this is basically describing a case of chronic inflammation. And if you guys remember, we said macrophages are the most important alongside lymphocyte, but macrophages are the most important when we have a chronic inflammation case. Now here we have a 19-year-old woman who works indoors and spends a day outside gardening. She does not wear a hat or sunscreen. And so you can think about sunburn or whatever in this case. And that evening her partner remarks her face appears red. And which of the following dermal changes are most likely account for her appearance? So if you guys remember, this is one of the, if you guys remember the 5 cardinal signs, so we had redness, hotness, swelling, loss of function. So this is what we see here, the redness. So what we said causes the redness, we said vasodilation, so or hyperemia, increased blood flow. So yeah, this is what's called vasodilation. So this is that's it for pathology revision. Now on to pharmacology. Okay, so for pharmacology, guys, I started with the like introduction of like the route administration, the pharmacodynamics and pharmacokinetics. I will be covering, I think, up to the pharmacokinetics. So we'll be starting with the routes of administration. So first of all, we have systemic versus topical. This is the very broad classification. So systemic would be basically reaching like every single part of your body. So, and topical would only be focused on one area. So for example, if you're putting like a cream or like acne cream, whatever, this will be like more topical. Systemic would reach the entire body. And systemic is further broken down into two parts, enteral and parenteral. So enteral is anything inside the GIT. So mouth, what's it called? Esophagus, intestine, stomach, rectum, anything that goes through this system is enteral. Parenteral is the opposite, so anything that does not go through your GIT. Now, enteral, we have three types: oral, sublingual, and rectal. So oral, from its name, it's the most common, it's the most convenient, and it can be released immediately or extended release. So extended release as in it would either like release it after a period of time, like after it reaches a certain part of your GIT, or it has been releasing slowly as you're going on. It does not release the drug any one time, it releases it slowly. Problem is it has liver first pass metabolism. So if you have a drug that can be metabolized by the liver, if you take it orally, it can be deactivated by the liver, and its effect of the medicine will be basically gone. Now, we have the other two actually like bypass this liver first pass metabolism. So sublingual, as you can see the picture at the bottom, it's put under the tongue and it diffuses into the capillaries. The special thing about this sublingual, it bypasses through the liver first pass. So if a drug gets metabolized by the liver first pass metabolism, you can put it sublingually and it won't be metabolized. Again, same thing with rectal. So it can be used when the oral intake is impossible. And again, it bypasses the portal circulation and minimizes the first pass metabolism. Now, finish the enteral route. We have parenteral. Parenteral, it can be transdermal. So as in, you can put it inside the skin and it goes through the skin, diffuses and goes towards the entire body. Injections, we have IV, IM, subcutaneous, etc., etc. And we have inhalation as well. So sometimes, for example, if anyone takes anesthesia before, you put like a mask on your face and they're gone. This is parenteral example. So when we do the parenteral route, so for example, if a drug is unstable in the GIT, so it become broken down by acids or alkaline in the intestine or acid in the stomach, or it's harmful in the GIT, or if a patient is unconscious, so we'd give them IV drugs, or we need a very quick onset. For example, if someone has like anaphylactic shock, wanted to put it like they usually give the epinephrine shot intramuscularly. We want a very quick like onset of action, so we usually give it parenteral. Now IV is the most famous. It provides rapid onset and has 100% bioavailability. So since we're putting the drug directly into the blood, all of the blood reaches the entire system. So it does not, for example, go into your, like, gets lost in feces or urine, whatever. It's you're going straight away into the blood. So, but a point to remember is you cannot administer suspension or oily emulsion. So if you have like a drug which is like suspension and it's not dissolved, or oily emulsion, or called a depot, you can't really do it on IV. On the other hand, we have intramuscular. You can put it inside any of the muscles. This, on the other hand, can be used with depot preparation for slow and prolonged release. And subcutaneous, you put it under the skin, and it's usually like slower than the IV route. An important concept here you guys need to know is when you compare the drug concentration inside the blood, IV, the bioavailability, or the amount of drug is present inside the body or inside the blood, to be specific. In IV, it has the highest drug concentration or highest bioavailability by far. It's 100%. But if you compare intramuscular, subcutaneous, and oral, it starts with 0 and it goes, depending on the route, it goes up. So if you can see intramuscular, it goes up first, and then subcutaneous, and then oral is like the lowest, as the lowest bioavailability out of all. But if you guys compare, like as you go along with time, the intravenous, the concentration goes down pretty quickly. This is why we said it's IV is mostly, or in general, the parenteral, but specifically IV is usually used for quick onset. And intramuscular, again, it goes down. Subcutaneous, all of those are parenteral, so their concentration goes down pretty quickly. And oral, even though it goes up slowly, but again, it stays for longer. And as a general rule of thumb in pharmacology, if a drug gets absorbed really quickly, it's gonna go away really quickly. But if it goes slower, it's gonna remain for longer. Now onto the pharmacokinetics and pharmacodynamics. So pharmacokinetics is a process where the drug is absorbed or distributed or metabolized by the body. So how the body interacts with the drug. On the other hand, pharmacodynamics is how the drug interacts with your body. I'm not sure if this makes sense, but try to think about it. So in pharmacokinetics, we have ADME, or absorption, distribution, metabolism, and excretion. I'm going to go in a little bit of detail about this. So first of all, the first step of any drug that goes into your body is absorption. So absorption is how it enters from whatever route it entered, or like the administration route, into your blood. So absorption, as general rule for absorption, if the drug is unionized, so it's not ion, it's not like a hydrogen ion or a chloride ion, it's unionized, it's a compound with low polarity and high lipid solubility. So we need high lipid solubility to go through the membranes, and it's easier to diffuse, they're easier to penetrate the membrane. Everything opposite, it's even harder to penetrate. So if an ion is ionized, it's high polarity, it has lower solubility. These are difficult to penetrate the membrane. So again, if you have any acidic drugs, they're usually best absorbed in the stomach. As we said, that we want our drugs as unionized as possible. So if you have an acidic drug which is in the stomach where it's acidic environment, it's going to remain unionized. This is the best part. This is the best place where the drug is absorbed. On the other hand, if you have a drug which is a base or an alkaline, we want it again unionized, so it's best absorbed in the intestines. So in drug transportation, how it goes through, like from your stomach or intestines into your blood, you have two modes. We have passive diffusion and protein or mediated transport, or carrier mediated. We have facilitated transport and active transport. So passive diffusion, you guys pretty know everything about it. This equation, you don't really have to memorize it, but understand it. So we have D, which is the diffusion coefficient. So like this is like a predetermined number for each drug, and molecular weight of the drug will determine. So if we have a high molecular weight of the drug, and this is gonna make it harder for the drug to dissolve or like diffuse. And if you have a lower, it's gonna make it easier. Again, A is surface area. So if you have a higher surface area, it's gonna make it easier to dissolve. And again, important thing is difference of concentration of the fluid. So if you have, for example, you're comparing the concentration of the stomach to the blood. If you have high concentration of drug inside the blood and low concentration in the stomach, it's going to make it easier, but or make it harder, I mean. So if you have high in the stomach and low in the blood, it's going to make it easier. If you have high in the blood and low in the stomach, or equal in the stomach, it's going to make it harder to diffuse. Protein-mediated transport. You guys know, sometimes we have uniporters, we have symporters, antiporters, and this usually we need usually a carrier protein or something to facilitate this type of diffusion. Again, it's non-energy dependent. Now we have active transporters. Active transporters, on the other hand, do need energy. So sometimes we have primary active transporters. So if like ATP or like a transporter that uses ATP itself and makes it transport. Secondary transporters utilize energy from another transporter, so it uses the energy gradient to another carrier protein, uses primary active transport to create this imbalance, or like puts the ions on, like for example, outside the cell, and the ions would go from outside the cell into the secondary transporter and go through it without using energy. But it's technically it's using energy from another uh, what's it called? Another protein. So sometimes we have symporters or sometimes we have antiporters. So symporters, both of them, like both of the molecules are going through the same, like going towards the same. So inside, for example, inside the cell or outside the cell. Antiporters, they go opposite. Um, Now, for example, here we have the what's it called? This title is wrong, but يعني, these are the things that would affect the absorption of the drug. So we have drug properties. So we have lipid solubility. Again, we talked about those, and route of administration. If sometimes the drug is enteric coated, so we don't want the drug to dissolve inside the acid, or sometimes we want the drug to dissolve in the intestines, would make it alkaline sensitive. Sometimes have sustained release. We want the drug to like release again, as you mentioned before, in like a slow concentration over a long period of time. And yeah, sometimes we have topical, which depends on the lipid solubility. Blood flow to the absorption site. If we have an organ, for example, the intestine has a much greater blood supply compared to the stomach. So what's it called? The absorption in the intestine will be easier. Total surface area, the greater surface area, the better. And again, contact time. So if you have less time in contact with an organ, this would cause less absorption and expression of P glycoprotein, which it's actually, if I'm not sure if you guys took it in macro yet, but sometimes it's a virulence factor for bacteria. So sometimes we take certain antibiotics and bacteria would have this P glycoprotein, which once the drug enters the bacterium, it actually pumps it out of the cell. Another important concept is bioavailability. So if you see this curve, this is what's in gray is the area under the curve, and the bottom, the x-axis, we have the time, and the y-axis, we have the concentration. So we can see here the onset time is at this specific concentration. This is where we can see the effects of the drug. This is the minimum effective concentration. Now, if you continue going up, this is Tmax, or maximum concentration, and Tmax, this is the time where we have the maximum concentration. This is where the maximum effect is. Now, if the concentration of the drug goes below the minimum effective concentration, we can't see really the effect of the drug. Now, if you go upwards, we can see here the minimum toxic concentration. The minimum toxic concentration is where we see with the toxic effects of the drug, or we can see the side effects of the drug. And this is where we don't really want to reach. And the area where, so if you think about it, where do we want the drug to be? We want it between the minimum effective concentration, where we want to see the effects, but we don't want it to reach the minimum toxic concentration. We don't want to see the side effects. And this area is called the therapeutic range. This is where the pharmacologists or the scientists behind the drugs, they calculate the dosage based on this therapeutic range. They want the drug to be inside this area. Now, this is the concept of the loading dose. So how do we, like, for example, if like sometimes you would like to take drug, let's say the doctor tells you 3 times per day, or sometimes another doctor would say, okay, for the first day, each time of take it 3 times per day, but take, for example, 2 pills instead of 1 pill, and then after that take 1 pill each day. This is how the concept again of the loading dose. So if you see on the left hand side, the first patient took the drug once, and then خلاص, he didn't take it again until he's waiting for the next dose. He didn't really reach this therapeutic range, and he barely reached the minimum effective concentration. But on the other hand, if you have the other person who took a loading dose, so he took, for example, instead of taking 1 pill, he took 2 pills. and he reaches the therapeutic range, and then now instead of each time instead of taking the loading dose taken once, and then after that we're taking the maintenance dose only because we don't want it to reach the minimum toxic concentration. So now here, if you can see on the right hand side, the patient's blood level of the drug is, yes, it's in the therapeutic range always. And yeah, this is the concept behind the loading dose. Pretty important. Now we finished absorption. Now onto distribution. So distribution is how the body, how the drug reaches like the part of the body where it wants to reach. So the factors affecting distribution, for example, first is blood flow. Again, like the absorption, same thing. If an organ has rich blood supply, it's going to reach more of the drug. Capillary permeability. Important thing is binding of the drugs to plasma proteins and tissue. So if sometimes certain drugs are made and they're bind to proteins inside the blood, this would decrease the distribution. The drug would remain inside the blood rather than go to the tissue. And again, lipophilicity of the drug. They're very similar to the absorption. Now, volume distribution is a pretty important concept, and it tells us how extensively the drug is distributed to the body compared to the plasma. So again, if the drug is restricted to vascular components, so if you want a drug to remain inside the blood vessels, so for example, if you want like a drug that decreases coagulation of the blood, for example, if someone just had a heart attack or a clot inside the blood, and we want to give warfarin or whatever into the patient, we want the drug to remain inside the blood vessels. So we want the drug to have a low volume of distribution. Sometimes a drug that can accumulate inside another drug, we want it to go, for example, to the liver, to the brain, or whatever. We want it to have a high volume of distribution. Now, the thing about drugs with high volume distribution, they can also, on the other hand, it's like a double-edged sword. As they have higher volume distribution, the side effects can become more common since it's reaching more of the body. So if you can see here the volume distribution, again, all of these equations, I don't think they're gonna, or they might ask you to calculate, but most importantly, know the relationships. So if you can see here the plasma concentration at time 0, if we increase the plasma concentration at time 0, the volume distribution decreases. So what does this mean? So this means that if you have a high plasma concentration of the drug, that means that the drug is remaining inside the blood vessel. It's not really going to the tissues. So this means the volume distribution is low. And the amount of drug inside the body, so if you have a lot of like the drug inside the body, this means high volume distribution. Now, volume distribution also can be used to calculate the dose required for the target plasma concentration. So when calculating the dose, we have another concept called the bioavailability fraction. And again, bioavailability fraction is like how much of the drug that's sticking within whatever route it is actually goes inside the blood vessels or inside the systemic circulation. So if, for example, here we have 100 milligrams of drug administered orally, only 70 milligrams is absorbed. So the bioavailability fraction would also only be 0.7. So if I'm calculating the loading dose, if we have high volume distribution or high target concentration, we would need a higher dose to recover. But if you have a drug that has a low bioavailability fraction, we'd like to have a higher dose. We want to compensate. We need like a higher to compensate the difference in concentration. Now, onto the third concept is metabolism. So the metabolism, usually most drugs are metabolized inside the liver, and its main purpose is to convert the lipid-soluble drugs into water-soluble metabolites that are easily excreted inside the kidneys. So when we said before, for absorption and distribution, we want the drugs to be more lipid-soluble. But when it comes to excretion, we want it to become easier, water-soluble, so it's easier by the kidneys. And we have two phases for metabolism. Phase 1 usually involves oxidation reduction or hydrolysis, and usually utilizes the cytochrome P450 system. So this is the first step. And the metabolite of phase 1 can be active or inactive. Now, in phase 2, you have conjugation reaction, or most famous is glucuronidation. And this is where we add a huge polar group to the drug to increase the water solubility. And this is usually the final step of metabolism. So metabolism is usually inactive, except for morphine 6-glucuronide. As you guys might take later, morphine is one of the only drugs that would actually get activated after liver metabolism. But most drugs usually get inactivated with liver metabolism. So factors affecting metabolism. So sometimes we have drug interactions. So if you guys took like pharmacology, sometimes we're gonna have an entire slide on drug interactions. So if I'm taking a certain drug, which drugs I can't take with it, since it can inhibit or activate these certain enzymes that are metabolized by the same enzymes. So if we have sometimes we have inducers. So have, for example, I'm taking a drug that's metabolized by the CYP for 50 enzymes. Another drug at the same time which increases the activity, which can increase the cause faster metabolism and have decreased effects of the other drug. On the other hand, inhibitors would inhibit the enzymes, which can cause higher plasma levels, which can predispose to side effects. Sometimes we have genetic polymorphism. Sometimes people are like on their own, the rapid acelerators or slow acelerators. So they metabolize the drug either quickly or slowly. And sometimes we have pathological status. If someone has liver cirrhosis or heart failure, it can affect the metabolism. And again, also age. Clearance is how a drug is removed from the body. It's so we have other implications where we can use this clearance. So if we have higher volume of distribution, the drug is distributed more into our tissues. We have higher clearance. We want to remove the drug, and we need to, like, the drug is more into our tissues. We want to, and we need a higher rate of clearance to remove this drug. And the total clearance is composite estimate reflecting all mechanisms of drug elimination as calculated as follows. So clearance is this constant at times the volume distribution. So if we have higher volume distribution, we need higher clearance, and is inversely proportional to the half-life of the drug. So if we have a drug with a higher half-life, it remains like longer in the blood. It's not really excreted yet, so the clearance rate will be lower. Lastly, we have excretion. So we have types of excretion. We have biliary excretion, enterohepatic circulation. An important concept is ion trapping. So if you guys remember when we talked about absorption, we said that acidic drugs are better absorbed in the stomach and basic drugs are better absorbed in the intestine. So here it's actually the opposite. So we want the drugs to be removed. So if we have a drug which is a weak acid, it can be eliminated by alkalization of the urine. So when we eliminate the weak bases, it can be increased by the acidification of the urine. So, for example, if you can see here on the picture on the right, so if acidic drug, it gives it as an unionized and becomes ionized, and the basic drug is ionized and it becomes unionized due to this acidification or alkalization. And a last concept is the maintenance dose rate is equal to the elimination rate. So again, this is all due to not increase or not go over the minimum toxic concentration. And yeah, that's it from my part. On to Ahmed for the micro review.
Thank you very much, Andrew, for your wonderful explanation. Now I'm going to take over from now. So, assalamu alaikum, everyone. I'm Ahmed Abubakr. So I'm going to do the microbiology review. So let's get started. So first of all, we need to understand the difference between prokaryotes and eukaryotes. So prokaryotes, which are simple cells, they don't have nucleus, so they don't have nuclear membrane. As for the eukaryotes, they have normal, just like our cells. As for the DNA structure, prokaryotes, they have a circular DNA. As for us, we have the chromosomes. Membrane-bound organelles are not present in prokaryotes, while they are present in eukaryotes, which are, for example, fungi and parasites. And cell division in bacteria, which are the example of prokaryotes, are binary fission. While in eukaryotes, which are the normal things that we know, it's mitosis and meiosis. Now, ribosomes are different from prokaryotes and eukaryotes, which are smaller in prokaryotes, 70S, and larger in eukaryotes, which are 80S. Next slide. So we're going to explain the viral world. So let's start with viruses because they are weird. There are debatable um, ideas that it might be alive or not. So, but we all know that the viruses are small. They are tiny. They cannot be seen with light microscope. You need an electron microscope to see them. Secondly, their genetics are weird. So they can only carry one type of nucleic acid. It either can be DNA or RNA, but never both. Thirdly, they depend on living inside the cells. That's why we call them obligate parasites. So they cannot reproduce it on their own. They must get inside the cell and get multiple copies of themselves. And last but not least, they are what's their purpose? They make diseases by destroying our own cells and triggering the immune system. So next, we're going to talk about the eukaryotic pathogens, which are the two, fungi and parasites. So fungi, they come in three flavors. So yeasts are unicellular, and they reproduce asexually. So they just bud off the new, they are like budding off the new cells. Molds are multicellular, and they are filamentous. They look fuzzy, like a fuzzy carpet, and they grow filaments, which are called hyphae. And they also they like reproduce sexually or asexually. And important features of fungi, which are that they are dimorphic, so they can shift between the yeast form and the mold form. Moving on to the parasites, we have the unicellular and multicellular. So the unicellular are the protozoa, which comes from the word protos, and the multicellular, which are the hemolith. And for example, we have the tapeworm. And what's important, what two features that we can see about parasites that they can be seen with the naked eye, in the case of hemolith, and they have a complex life cycle where they must go between different cells in order to complete their own life cycle. So moving on to the bacterial cell wall. So what are the key structures in the bacterial cell? We have the capsule, which is a slimy layer, which found outside the cell wall. And think of it as a force field. So it prevents your immune system from eating the bacteria. So there will be no phagocytosis. Moving on to the cell wall, which is a rigid layer formed of peptidoglycans. So it gives the bacteria its shape and it prevents it from bursting. And this is where the antibiotics come and target the cell wall. Moving into the flagella is like a web-like structure that acts like a propeller. So it's mainly for the movement of the bacteria. And pellies, which are hair-like structures, so they help the bacteria to stick into structures, and they can also help it in transferring genes like DNAs. So let's talk about the internal structures and survival of the bacteria. So we have also, we have discussed what's a ribosome. So the ribosomes are 70S in prokaryotes, which are bacteria. Moving on to the plasmids. So plasmids are small loops of accessory DNA. They are not essential for their daily life, but they are like additional powers for the bacteria. So they can carry extra genes like antibiotic resistance and toxin genes. And endospores, they are like survival pods. So when the bacteria sense that they are in a very bad condition, like for example, they're exposed to heat, radiation, or alcohol, they can just turn them into the reduced form, which is the endospore. And this endospore is special. It can be produced by Bacillus and Clostridium, and they can also within that endospore form they can survive in harsh environment. So let's understand the different shapes of the bacteria. So we have the cocci, the bacilli, and this subrocatus. So the cocci are spherical in shape, so they can form like grapes, or they can be in chain and like doubles. Bacilli, they are rod shaped, So we can think of different bacteria like E. coli and Salmonella, which are bacillus in shape. And we have the subrocutus, which are spiral shaped. So think of like a corkscrew. So its shape, it can help the cells to penetrate any like obstruction. It's like a screw to a surface in simple. Moving into the bacterial genetics. So we have this concept called the horizontal gene transfer. So it's divided into three main concepts, which are the transformation. So when we talking about transformation, so the DNA or it gets sucked by the bacteria, and this DNA itself came from a dead bacteria or from the environment itself. Now, when we're talking about transduction, so there is a virus that translocates the DNA from one bacteria to another. And when it comes to conjugation, it's just like direct transfer via the sex pili. So, and this is one of the ways that the bacteria can form resistance against with the antibiotics. And now we talk about the genetic elements, which are the mutations that happens inside the DNA. Um, so, so there are some different mutations that goes inside the DNA of the bacteria that can actually cause them to upgrade themselves and cause evolution. Okay, so the next slide is going to talk about the dynamics of disease transmission. So first of all, we have the host to host spread. So some illnesses like food poisoning or in like from bad food. Um, so it can rely on passing the disease from one person to another, or it can, for example, like tuberculosis. It when someone coughs and the other person breathes in, so it gets the infection. So, and we have the contagion. So some diseases, like they are so easily to spread. That's why we can call them contagious diseases. So we have diseases like measles, COVID, and flu. And now we need to understand the three terms, which is the endemic, the epidemic, and the pandemic. So the endemic, which means that the disease is always there, but it's huming at the low levels. For example, in malaria in Africa. Epidemic, it's like the cases of the diseases are increasing. So there's more cases than usual. And a very good example of it is like seasonal flu every winter. And a pandemic is like when the spikes of cases goes globally. So it goes over the world, over the continents. And very example of it is COVID-19 and also HIV. We need to also understand in the next slide that the progression of infection. So we have the first stage, which is the incubation. So this is a silent phase where the pathogen is multiplying inside of you multiple times. And what about you? So you are completely asymptomatic. So you don't see anything wrong in your body. This is where the second stage, where the prodromal stage comes in, where you start feeling something that is very weak. To start with, like mild fever, you start to feel a bit tiredish and a little achy. So, and this is where the disease is still developing, but you start developing a little bit of symptoms. Moving on to the third stage, which is the acute illness. So this is where the disease hits, the specific symptoms hit. So you cough, there is the rash, there is the diarrhea. So this is where the disease actually happens. And you feel awful and you feel sick. The fourth stage, which is the recovery stage, this is when your immune system went against the infection itself, and you restore your energy back, and you get back to normal. So let's solve some questions related to this section exactly. So the first question is which method describes the transfer of genetic information in bacteria by direct cell-to-cell contact? So Any answers? Okay, so the correct answer is C, which is conjugation. Um, Conjugation, as we explained before, is like transferring the genetic materials between two cells through the sex splice. So yeah, it's quite straightforward. Next question, which is a sudden outbreak of flu virus is a specific in a specific region, is an example of what? So awaiting your answers. Okay, it can be, yeah, it cannot be A because we're talking about a sudden outbreak of a virus. So we're talking about cases of the infection itself has spiked. So if you're talking about endemic, the disease is always there, but it does not have high levels of infections among individual group of people. So the correct answer in this question, epidemic. So what's epidemic? It's just like an endemic, but when the cases start to rise. So it's like an outbreak of virus in the region, as the question says. So let's move into the second section, which is the bacterial structure. So let's start first with the cell envelope, as we have explained before. Cell membrane, cell wall, and the outer membrane, and which is the differentiating factor between gram-positive and gram-negative bacteria. Speaking of gram-positive and gram-negative bacteria, the next slide is going to just to review the differences between them. So gram-positive bacteria, um, next slide, please. So yeah, the gram-positive bacteria, they have a thick cell peptidoglycan layer, while the gram-negative bacteria have a thin peptidoglycan layer. So there are some, since the gram-negative bacteria have an thin outer peptidoglycan layer, they have something which is an extra, which is the outer membrane. What is unique between the gram-positive and gram-negative, which is the tachyoic acid in gram-positive and the liposaccharides in gram-negative. Now, when it comes to gram staining, the gram-positive stains purple, as we know, and the gram-negative stains pink. Next, which is the gram-negative shield. So let's focus on the gram-negative outer membrane for a moment. So it's like a tough layer that pushes anything harmful to the bacteria out. So when we're talking about antibiotics that targets the peptidoglycan layer, it cannot get into the gram-negative cells because the outer membrane is there. So it's like blocking the pathway to it. And another thing, which is the liposaccharides. So they are embedded in the outer membrane, and they are like endotoxins. So when the bacteria dies, it breaks apart and the liposaccharides get released, which triggers a massive immune response, which can cause fever, inflammation, and in bad cases, it can cause septic shock. So what do we mean by glycocalyx of the bacteria? So it's a slimy coating, and we need to differentiate between like the capsule and the biofilm by understanding what's the difference between them. So if the slimy layer is organized and firm, we can call it a capsule. And the capsule is a major valence factor because it can act as an invisibility cloak. So it makes it hard for the immune cells to recognize and phagocytose the bacteria. Now, the unorganized and loose form of the slimy coating, which is the biofilm. And this slimy layer is just act like it can just stick the bacteria into the surfaces, like for example, catheter or heart valves, or for example, or teeth. And the scary part of the biofilm is that they are incredibly resistant to antibiotics. So a bacteria that has biofilm, it makes it harder for them to penetrate, antibiotics to penetrate it, and even harder for it to be killed. Now we need to understand the outwards of the bacteria, which helps it in mobility and attachment. So next slide, we're going to talk about the movement and attachment of the bacteria. So for example, the flagella, which as we speak before, it's a whip-like structure that helps it propel, rotate, and drive them forward. So it can swim between nutrients and even drive away from toxins. And we call that chemotaxis. Now the fimbriae, when we come think about it, it's a short hair-like structure that covers the surface of the bacteria. So they act like a Velcro, letting the cells latch into specific host cells, and which can cause like infections, for example, upper respiratory tract infections or urinary tract infections. So they stick and don't let go. So another feature, advanced feature for the bacteria, which are the pili. So pili are rigid tubular structures, and they are specialized for the process which we talked about, which is the conjugation. So there is a bridge that forms between the two cells that transmits the DNA in form of plasmid. So this is the primary way how bacteria form resistance against antibiotics. So they can just pass down the genes between the neighboring cells, and they don't need to be even related to each other to receive the genes. Now these features are can be produced like cells, bacillus, as we said, bacillus and clostridium. So so they are dormant and indestructible form, and um, and they can they can be resistant to heat, radiation, and chemicals. This is when we talk about the endospores, especially like the ones that are produced by bacillus and clostridium. Next slide, which is going to talk about the internal structures again. So this has been explained before, which is the ribosomes. So ribosomes specific for the bacteria are very important because they can be targeted by antibiotics. So we can make antibiotics like triglycerides, tetracyclines, that targets the bacterial ribosomes and shut down the protein synthesis pathway. Plasmids, yeah, we said before it's used in the conjugation form, so it can used to transfer supergenes. As for the nucleoids, which are the central region where the single circular bacterial chromosomes lives. So unlike the cells, as we know, the prokaryotes, they don't have a nuclear membrane, so they just have the nucleoid where their genetic material resides. Another important topic to talk about, which is the binary fission. So it's just simply tells us how the bacteria multiplies. So which is called the binary fission. So it's a simple, beautiful pathway, where the first step where there is a replication of the DNA, and then the cells of the bacteria elongates, pulling the two DNA copies apart, and then a new wall forms, which called the septum, forms in the middle, and finally these two cells will go to split apart, forming two identical daughter cells. This is a very fast process. It takes about every bacterial cells can divide like 20 minutes every 20 minutes, and they can like make a million copies of themselves in very few hours. Let's move into the third section, which is the bacterial classification. So how do microbiologists classify bacteria? So it's based on three categories, which is the morphology, the shape of the cells, and the arrangement of it. And then we have the cell wall structure, which what's the main differences between the gram-positive and gram-negative bacteria. And the third thing, which is their utilization of oxygen. So there are some bacteria that need oxygen, which we call it aerobes. And we have some bacteria that get harmed by the oxygen, which is called the anaerobes. And we have the ones that adapt between having oxygen or not. So these are the three pillars. Moving on to the bacterial morphology, as we explained before, but I'm going to add a point, which is the cocci can be in pairs, which is called diplococci, and they can also form chains which are called streptococci, and they can also can patch up in grape-like clusters, which are called staphylococci. Now, bacilli can be short and stubby, like cocobacilli. So we call them cocobacilli because we cannot differentiate between it can be either cocci or it can be bacilli, or it can be normally like long and slender bacilli, as we know. Now, we have some odd types of bacteria, which are called Vibrio. So they have like a comma-shaped, they are comma-shaped. And we have the spiralum, which are corkscrew shape. So shapes of the bacteria can tell us about their different classifications when we look at them under the microscope. Now let's move into an interesting topic, which is the scientific nomenclature. So how do scientists actually name the bacteria? So it follows the same binomial system like the plants and the animals. So they have two names like the genus and the species. So the genus, which is the family of the bacteria, and it's actually spelled in a capitalized manner, and the species, which is the specific genome, yani the specific species of the bacteria within the genome, are lowercase. So when we're talking about, for example, Staphylococcus aureus, so when we say the Staphylococcus is the genus, while the aureus is the species. Now, there is a whole like big rank of organisms throughout the domains, kingdoms, phylums, classes, order, family, genome, species. But for clinical purposes, we just focus on the genome and the species. So how can we differentiate different gram-positive cocci? As we know that the gram-positive cocci, they are stained purple. So how can we differentiate between different gram-positive cocci is through the catalase test. So the catalase positive bugs grows in clusters, like for example, staphylococci. So Staph aureus is the big one, which causes like skin infections, abscesses, and food poisoning, while the catalase negative bugs, they grows in chains, which are called streptococci. So we have, for example, like strep pyogens, which give you a strep throat. We have the strep pneumonia, which actually causes you pneumonia. And we have the enterococci, which is a big cause of urinary tract infections. So it's a very simple test. It just differentiates between the two, Staphylococcus and Streptococci. Now let's move into the gram-positive rods. So they are like a mixed bag, and we separate them mostly by their utilization in. So the aerobes, as we know, the bacteria that needs oxygen, for example, like bacillus. So they form spores and they cause anthrax. Listeria, another example of the aerobes, can cause meningitis in newborns and elderly. And we have the corynebacterium, which can cause diphtheria, which is a disease. And we have another group, which is the anaerobes, the bacteria that hates oxygen. So Clostridium is a one big group in the anaerobes, and we have certain diseases like tetanus, botulinums. We have gas gangrene also. And we have another group, which is the actinomyces, which forms abscess in your mouth or neck. And like a huge clue for these groups is like the spore forming ability. So let's move on to the gram-negative bacteria. Gram-negative bacteria, they have thin cell wall and outer membrane, as we talked earlier. They stain pink and they can be pink or red. So the main two shapes, which are the cocci, for example, like Neisseria meningitis, which causes meningitis, and we have Neisseria gonorrhea, which can cause the disease called gonorrhea. And we have most of the gram-negative rods, gram-negative bacteria are rods, and they form in a huge group. So they can like inhabit in your GIT. It can inhabit in your respiratory. It can be also found in the environment. So they are everywhere and they can cause also a lot of diseases. So let's zoom in one of the families, which is the bacteria. So enterobacteria are gram-negative rods, which lives in the gut. And from the name, it's entero, so it's related to the GIT. So they are found everywhere in the soil, the water, and even in the human GI tract. And they are responsible for many human diseases like E. coli, which is the main player in this family, which is mostly responsible for 70% of the urinary tract infections. We have also like Salmonella and Shigella, which can like cause a major, like they are the major causes of diarrhea worldwide. And we have also like Klebsiella and Protus, which causes pneumonia and sepsis. So this family is actually really huge. So we were going to go into a hard to classify bacteria. So they are basically bacteria that aren't like fit to the classification that we have spoken before. So yeah, actually next slide. So acid fast bacteria, no, previous. Okay, so acid fast bacteria is like Mycobacterium tuberculosis. They have a waxy cell wall that resists the gram stain. So we need a special type of stain to see them. Spirochetes, like the bacteria is shown in the slide, so they can cause syphilis, the disease syphilis, and they are spiral shaped and like their shape, and they are so thin that we cannot see them under regular microscope. We have the obligate intercellular bacteria like chlamydia and rickettsia, so they cannot live outside the cells, so they must get inside the cell to live inside it. And we have the cells that bacteria that doesn't have a cell wall, which is the mycoplasma. So they have no cell wall. When the bacteria doesn't have cell wall, there's no gram stain, so it cannot be targeted by certain antibiotics like penicillins. Next slide, which is going to talk about the virulence factor, which is the capsule. So to wrap up the last thing about this section is the specific virulence factor, which is the capsule. Next slide, please. Yeah. So this is a major classification in medicine. So what makes capsule a virulence factor? They are a slimy layer that protects the bacteria from being eaten by the immune system or immune system cells. So they are a group of encapsulated bacteria that can cause serious diseases. So, and they are grouped in the mnemonic SHIN. Okay. So the SHIN bacteria, which includes Streptococci pneumonia, we have Haemosyphilis influenza type B, and we have Neisseria meningitis. So think of it as a capsule, and we need to think of the capsule, and we need to think of the vaccine. So they are very important for the bacteria to evolve. Moving on to the bacterial genetics. So the bacterial genetics, we need to understand why these small bacteria contain genes that makes them so powerful against our body. So they contain antibiotic resistance through the plasmids, which is transmitted between two bacteria. We have and these genes are very important for the vaccine development, which is very important for us as an immunological process. And they have a they have a quick, rapid adaptation to the harsh environment. So what's the part of the genetics inside the bacteria that is important for it to function? So next slide is going to talk about the bacterial genetic materials. So next slide. So we have two types of the genetic materials. So we have the chromosome of the bacteria, which is a very big loop of DNA, which is essential for its own survival. And the other type, which is the plasmid, which is a tiny loop of DNA, which is not essential for survival, as we said. And they carry out the very important specific superpowers that let the bacteria survive or evolve, like, for example, antibiotic resistance and the toxin production. So, as I said before, in the next slide is going to specifically talk about the plasmids. So, what makes plasmids so powerful? Next slide, please. Which are two main things: that they can copy themselves independently, so they don't wait for the cell to divide, so they can replicate inside the cell independently. And secondly, which is the scary part, which is they can be transferred, like as we said before, the conjugation process. And they carry out the most important genes, which are the antibiotic resistance and the toxin production. Next slide, which is going to talk about the DNA replication for the bacteria. So it's a very simple process. So it starts at a specific spot, which is called the ORIC, ORIC, capital C. And this is where the enzyme DNA polymerase comes in and zips along unzips the DNA strand into two strands, and then this is where they produce a new matching pair of the DNA. So in the end, you have two copies of the DNA for the bacteria, which is a very simple process, unlike the DNA replication in humans. Now we need to understand, after we produce this, or we have made bacterial genes, we need to understand what's the difference between the genotype and the phenotype. So next slide. Genotypes are the genetic blueprints. So this is where all the genes of the bacteria carries. And it also represents the potential of the bacteria, while the phenotype is the actual physical result. So what can we see from the changes in the gene? Is it resistant to antibiotics or not? Is it producing toxins? This is the phenotype. So in a simple way, you can think of that the genotype is the recipe, while the phenotype is the actual cake. Now, moving on to the horizontal gene transfer, I have explained this before. This is how the bacteria transfer the antibiotics resistance between each other. So let's move on to the next slide. And this was also explained before, which are the three mechanisms of the transferring of the genes. So we have the transformation, transduction, and the conjugations. So let's move on to the next slide, where we're going to talk about the mutations. So this is where the bacteria actually evolves. So mutation is just like a typo in the DNA sequence. They are harmless, but there are certain times that makes changes, and there are some that doesn't cause change. So, for example, when talking about some silent mutations, there are changing the nucleotide sequence, but it doesn't make it meaning. So there is no big deal. There is no change in the protein, so it's totally harmless. Missense mutation, when there is a one-letter change in the bacteria in the nucleotide, but it produces a different protein, but it functions the same way. So this is why we call it missense. And nonsense mutations, this is when we insert a stop sign very early in the DNA long chain. So the protein is going to get shorter and eventually is going to fail. Frame shift mutation is when we add an additional nucleotide or we delete one. So this is going to this is going to change the whole sequence, which is quite disastrous. And the last but not least, we're going to talk about, which is the mutations actually cause maybe due to random errors, or it can cause due to UV radiations. So these are the raw materials for evolutions. So let's move on to the questions. What is the complete set of genetic information in the bacterial cells? We have A, genomes, B, genotype, C, phenotypes, and D, plasmids. So please pick an answer. Okay, so the correct answer, which is the genome. The genome, which is which is found in the nucleoid of the bacteria, carries out its essential functions for survival. Okay, so this is for this section, which let's move on to the normal microbiota. So we have talked about bacteria as germs and superbugs, but truly inside of our bodies, most bacteria are our friends. So this is where we are going to talk about the ecosystems inside the bacteria that lives inside this. For example, in the mouth, it can live in the skin, everywhere in our body, and they can like yeah. So a problem in that microbiome, okay, and the microbiome in the bacteria can cause something called dysbiosis, which is an imbalance in the bacterial microbiome, which can, this is where this disease actually starts in the normal microbiome. So next slide is going to talk about the major like groups of bacteria that are present in our bodies, like for example, actinobacteria, firmicutes, uh, proteobacteria, and bacteroidetes, which are fancy name, but the first most important thing we need to know is just the headliners. So what shapes our like our personal microbiome? Factors like, for example, your age, your diet, your personal hygiene, and most importantly, antibiotic usage. So antibiotics actually is like a nuclear bomb for these bacteria in your body. So moving on to the first foremost microbiota, which is the gastrointestinal microbiota. So we have a huge number of micro bacteria in our body that are even out like more than our cells in our I mean, we have large amount of anaerobic bacteria in our body that actually outnumbers our own aerobic bacteria in the GIT, specifically in the large intestine. That's why we can say that there are a lot of anaerobic bacteria than the aerobic bacteria because it's taught the environment there is no oxygen. What are the star players in these microbiota? We have E. coli and we have bacterioids. So yes, E. coli, they are harmless, but they can help us digest food and make vitamins, important vitamins for our diet. The second microbiota, which is the oral microbiota. So it's in our mouth and it changes over time. So for example, in a baby, when it's born, it's sterile at birth. It's completely clean. But this is but the main shifting points is when teeth comes out from the baby. This is where everything changes. So teeth gives the bacteria a hard surface to stick in, and they can just do their own functions there. So excessive bacteria in the teeth can cause like dental plagues. So it's like a biofilm, a structured community of bacteria that glued to your teeth. They are normal to some, but a bit too much of that biofilm is going to cause cavities and gum diseases. Next, which is the vaginal microbiota. So this ecosystem is actually incredibly dynamic. So after puberty, lactobacillus take over, and it's the main hero bacteria in the hair. So they produce glycogen and so no, they eat glycogen and produce out lactic acid, which keeps the environment there acidic, and low pH keeps the bad bacteria away. But this is actually changes when the menopause came, and during menopause. So the estrogen levels drops, and then when estrogen levels drops, lactobacillus decreases, and this is going to increase the risk of infections, which is going to cause different diseases in the vagina. So, what do you think about the microbiota? Is it friends or the foods? Well, let's talk about the benefits that we can think of the bacteria. So, bacteria in our body, they are very important for metabolism. So like they can help us digest stuff that we can't, and they contain fibers, and they can make vitamin K and vitamin B12, which is very essential for our diet. So it's just like free nutrients for us. Secondly, which is the protection. So they can take up space and eat food in the microbiota. So they can outnumber the other bad bacteria and takes up their spaces. And this is actually called the competitive exclusion. So a high number of good bacteria is going to prevent the bad bacteria from destroying our lining. And last but not least is immune training. So actually these bacteria, they can train the immune system what to attack and what to ignore. And without them, your immune system going to get confused and overreact and then causes allergies or autoimmune reactions. So let's move into the last part of this section, which is the dysbiosis and diseases. So as we explained before, dysbiosis actually when happens when there is an actual imbalance between the bad bacteria and the good bacteria. So the bad bacteria is going to take over, which is going to cause a lot of diseases based on the different tissues in our body. And what causes these dysbiosis, which is the biggest problem, which is antibiotics. Excessive antibiotics use is going to kill the normal microbiota bacteria and going to allow these bad bacteria to evolve inside. We have other factors like, for example, poor diet and chronic stress. And we have found actually that in certain researches, they said that this bias is actually also linked to other diseases like, or let's say, other pathological conditions like obesity, diabetes, allergies, or even autoimmune diseases, or even difficile infection. And it can also increase the cancer risk. So it is very important to take care of your gut health and to help your own bacteria. So let's move into a simple question here, which is simply, what is the microbiota? So is it A, collection of all genomes and genes in a specific habitat? Or is it B, ecologic economies of conventional and pathogenic microorganisms? Or is it C, microorganisms that resides exclusively on the skin? Or is it D, which is a collection that only pathogenic organisms in the body? So the correct answer is actually B, which is an ecologic economies of commensal and pathogenic microorganisms, as explained before. Another question, which is an outbreak of Staph aureus sepsis occurs in a newborn nursery. Based on the normal flora, what is the most likely source of Staph aureus? So this is actually like a memorization question. So you need to actually know what certain bacteria and where do they live exactly. So answer so the answer to this question is actually C, which is the nose. So the last part of our review, which is the microbial diseases. Let's jump in. So we need to understand what is actually the word pathogen. The pathogen is any is any microbe that causes a disease. So here's the thing, it's not actually automatic. So just because the pathogen is there, it doesn't make you sick. It's actually a whole process. So it has to stick into you. It needs to invade the tissue and evade the immune system, and it has to grow and reproduce, and it can produce toxins. So any miss in these steps is going to cause it's going to break the process of the disease. So we have two main types of pathogens, which is the primary pathogen. So they when they enter the host, like a healthy individual, they make him sick directly. So examples like influenza and malaria. And we have the opportunistic pathogens, which we call the cowards. So they can only attack you when you are defenseless or your defenses are down. So, example like hospitalized patients or immunocompromised patients, they actually have weak immunity, so they can get these type of opportunistic infections. Next, we need to understand the difference between two uh, terms, which is the pathogenicity and the virulence. So pathogenicity is actually a simple term, uh, which yani, a simple term. So we ask the question, does it cause the disease or not? So it's like a yes or no question. As for the virulence, is we need to understand how much disease does it cause. So it's like a scale. Okay, so I'm going to continue. So virulence is like a scale, so it's going to um, tell us how much disease does the bacteria cause, how fast it is, how deadly it is, or how severe it is. So there are two numbers that we can use to measure the virulence of the bacteria. So ID50 is the dose needed to infect half of the people exposed. So the lower the number, the more infectious it can be. While the LD50 is the dose needed to kill half of the people. So the lower the number, the more deadly the pathogen is going to be. So in general, smaller the number, the bigger the trouble. Moving into the next slide, we need to explain certain virulence factors of the pathogens as we explained before, but here, like, it's more like generalized. So adhesins, which makes the bacteria sticks to certain cells, capsules, which are like the coating of the bacteria that protects it from the immune system. And we have enzymes that are going to like dissolve tissues and clear the path for them for invasion. And we have the toxins, which are the guns for the bacteria. So they are poisons that actually damage and kill our own cells. So we need Dexides is like what I explained before in the first part. So it's the difference between epidemic, pandemic, and endemic. So endemic is like in low levels. Epidemic is like when the endemic have an increased number of cases, and pandemic when it's like an epidemic but it spreads worldwide. Now we need to get to another concept, which is the chain of infection. So this is how the infection happens. So it has six parts of it, which is number one. Yeah, we need to explain it one by one. So number one, which is the agent. So it's the pathogen itself. Number two, which is the reservoir. So where does it live exactly, the pathogen? Is it inside the humans? Is it in animals? Is it in soil? The third thing, which is exit, how is it going to leave? Can it leave by coughing, by bleeding out blood, or by defecation, pooping? The fourth one, which is the transmission. So how does it travel? So it can travel in droplets, or it can by direct contact, or it can be through the air. Now, the entry of these pathogen is can be through the mouth, it can be through the nose, it can be through cuts. And last but not least, which is the host, which is this is the susceptible person who is liable to get the infection. So breaking any one of these chains is going to so the whole process chain of infection is going to fall apart. This is why public health is important in these cases. So how bacteria causes the damage? Um, so we need to understand first that firstly that they can cause it by direct invasion. So bacteria can like just go straight into the tissues and multiply and destroy as many as they can. So it's just like a direct physical damage. Secondly, which is the toxin production. So they can release poisons, which, as we said before, the guns of the bacteria. So they can like release poison that mess with our cells, shut down functions, and even makes hole through the membranes of the cells, which can kill the cells straight away. And we have the third thing, which is important. They can cause host inflammation. So sometimes the damage of the bacteria isn't from the bacteria itself. So it can be mediated by our own immune system. So when you get hurt in certain tissues, it's not because of the bacteria, but it's because our body fights too hardly. Now we need to understand the very important part uh, of this section, which is the next part, stages of infectious diseases. Next slide, please. So stages of infectious diseases, we have the first one, which is the incubation period. So this is actually a silent stage. So this is going to be, there are going to be no symptoms at all. So this stage actually in food poisoning takes last hours, or in rabies, it can last months. So you can be contagious, yeah, spread the disease without knowing. The next, which is the primordial period, as we discussed before, it's like when you have mild symptoms like mild fever, tiredness, and you're feeling a bit down. So nothing specific at all going to happen, but um, you're still trying to fight off the infection. The third stage, which is the acute period. So this is where the high mark or high, yeah, the high mark of the infection. So it's going to, the pathogens are going to multiply like crazy. So they're going to form symptoms like um, high fever, intense pain, coughing, and whatsoever. So you'll feel the worst during this stage, and this is where you can go and seek medical attention. And last but not least, which is the convalescence period. This is where the recovery actually happens. So the immune system has won against the infection, and then the infection gradually fades, and then your energy gets back, and you're feeling all right. Next, we're going to explain the differences between the endotoxin and the exotoxins. So exotoxins are released by bacteria, and the bacteria actively pumps them out like little poison darts, and they are like often be the most deadly thing on earth. So for example, like botulinum toxins, they are example of exotoxins. And then the other, which is the endotoxins, they are different. So they are part of the bacteria itself, as we discussed before in the gram-negative bacteria. So when the bacteria dies and breaks apart, it's going to release these small endotoxins, which are going to cause like triggered massive immune response, like fever, shock, and other. So in short, exotoxins, they are actively released and they are super potent, while the endotoxins are part of the cell released on death and they can cause inflammation. So last but not least, which is the types of exotoxins. Simply, we have three types. Next slide, please. Neurotoxins, which attacks the nervous system. So examples like tetanus can lock your muscles tight. Examples like botulinum can paralyze you. So those are neurotoxins. And secondly, which is the enterotoxins, which attacks the GIT. Examples like cholera, which can flood your intestine with so much fluid, so you can die from dehydration. And there is also example like E. coli, food poisoning. And third but not least, which is the cytotoxins. Cytotoxins just attack the cell directly. So, for example, like diphtheria toxins can destroy the cells in your throat and in your heart. So it can just be brutal and very excessive damage. So, in short, neuro stands for nerves, entero stands for guts, and the cyto, which is specific for certain cells. So, different toxins, different systems. So let's get to the last question of today. So the stage of infectious disease that presents as general sign and symptoms is it A, intubation period? Is it B, prodromal period? Is it C, acute illness? Or is it D, convalescence? Okay, so as we said before, that there is a general sign and symptoms like mild fever, like cough. It's not that yani alarming symptoms when we're talking about general sign and symptoms. So the answer actually is B, prodromal period. So thank you very much, everyone, for listening to my own lecture. It's I hope you get a lot of benefit from it, and thank you very much. And as always, Ramadan Kareem for everyone.